So how many fellows are on? Is it two or three fellows on the call?
Yeah, this is Mike Pompliano. I'm on.
Say that again.
This is Mike Pompliano. I'm on. I'll be
Okay,
joining Dr. Zem in a second too.
awesome. So this is really obviously for you guys and for future fellows and things like that. And I tried to throw this together and make it as entertaining as possible. I'm Rob Ames. I'm a former fellow from a few years back. Graduated in 2021 fellowship right out of the pandemic and came back home to New Jersey to practice. And I'm in a private practice now. Like a big, well, it was a private practice and then it got bought by a hospital, a big hospital system. So now I'm hospital employed, but started out in a private group. I'm not going to get into all of that really, just keep it kind of basic for how to kind of navigate the first few years of practice. That's a whole other talk in terms of like navigating types of jobs and employment contracts and all that. But this is just kind of a broad overview of kind of how to get through the first 3 years. That's all I can talk about because I'm just finishing up my third year now. So, all right. So this is transitioning to private practice. So there's always the talk about the three A's being available, affable, and able. And I think that those are good, but you also kind of have to know about the converse, which would be the other threes. This is the other side of the coin, right? Being absent, being overly ambitious in the OR, being taking on more than you should, and just being an a-hole. These are the things that you don't want to do. So we go through this and looking at both sides of the coin. Um, so as far as being present, being available, that's a really key thing in the first couple of years because cases are going to come your way if you're sort of letting people know that you're open to taking on new patients and being around in the hospital and doing add-ons and things like that. So in private practice in the beginning, especially you are going to be pretty slow in general. There's just not, it's hard to build up a lot of volume really quickly because nobody knows who you are and you're the new kid on the block. So being proactive and being always present. So that's, around the hospital, going to down to the emergency department, introducing yourself to the ER guys. You might regret that later, but certainly good in the beginning, just to get your face out there and let everybody know who you are. Um, Giving people your cell phone number, texting primary care doctors, other referring physicians, that's really super important. Um, and if someone refers a patient to you, this is a really key piece of advice that I got. It's not like, oh yeah, have them call my office. It's really more about give me the patient's number, give me the patient's name, their contact information, and I'll have my office call and get an appointment made for them. Um, that's really the key, is making it as easy as possible for the other for the referring providers and for the patients to get in to see you quickly. So don't be MIA. Be present and be proactive in going out and getting patient referrals and building your practice. For your spine partners, this is actually a really key thing that I kind of didn't really think much about when I was finishing fellowship. But you guys coming out of your training, you're going to have some really, really unique skill sets that probably the vast majority of people in your community are not going to have. So doing lateral access surgery and being trained at San Diego Spine Foundation, you guys have a really, really unique skill set to offer. And so letting people know, like letting the other spine surgeons in your community, especially if you're in a community setting, letting them know what you're capable of and sort of what your skill set is, will generate sort of referrals from your colleagues as well. Now, if you're in a different geography that's very saturated and has a lot of MIS guys out there doing, it's going to be harder to differentiate yourself. But across the country, there are going to be some places where you go where you're going to have a really, really unique skill set, and you should use that to your advantage. So that's kind of depending on where you go, but it'll be helpful. And guys, let me know if there's any questions. I don't know if there's, this hopefully can be like an open back and forth. Like if you guys have thoughts or questions about stuff, just stop me and we can talk. So hold on one second. Let me close this door. Sorry, guys. So as far as being too ambitious in the OR, I would say that in my experience, I mean, I definitely got in trouble in the beginning a few times in the first couple of years. You are very, very well trained and you're going to feel like you're able to tackle anything, but really you have to be able to take a step back and recognize that you're not in necessarily a situation um, where maybe the people around you don't know your preferences and don't have the same level of skill and knowledge for how you do things, and that can really slow you down, and it can really cause you really serious complications too, especially with x-ray techs and scrub techs and things like that. So the best advice I can say in the beginning is just start slow, do smaller cases, and keep it really simple in the beginning, and that's going to help you to stay out of trouble. And then just don't be an a-hole. I mean, this goes without saying, but treat everybody with kindness and respect. Treat your patients like they're your family. If they need a hug, give them a hug. That sounds really that sounds really like lame and sappy, but honestly, that's what people need when they're in your office and they're scared and they're worried. So like just treat them like they're your family. Do what you think is right and what you would want to have if it was your mom or your dad or your sister, and that's going to go a long way. It's really going to help you to build a reputation for yourself that is somebody that cares, and then the staff will see that, and then people will talk about you in a good way. And the same goes for treating all of the staff in the operating room, across the board. Just treat everybody with kindness, and it'll go a long way to generate to build your reputation, which is really what we're talking about. Okay, so I'm going to get in now to the first year, where my best advice for the first year is, and I'll break it down kind of over the next couple of years, like what year 1, 2, 3. But my best advice.
Who is mom and who is dad there?
Well, guys, who do you think?
Yeah, I'm pleading the fifth. I'm in the firing zone.
Is it a question? Okay. So, don't be afraid to call mom and dad for help, because you're going to be scared. If you're not scared, there's something wrong with you. I mean, that's my opinion. I think if you're not scared out of your mind, then you have an overly developed sense of self. Okay. There were many, many nights in the beginning where I literally could not sleep for hours. Okay. And that is what you hear about when people tell you, oh, you're going to go into practice and it's going to be harder than it's ever been before. And you're like, how on earth could it be possibly harder than it's ever been before, coming out of 12 or 10 or whatever years of training and all the hell that we all went through? And then someone's telling you it's going to be harder than that. And you have no way of like believing that, because it's just so impossible to believe. And then you get there and you're like, okay, yeah, it's harder. It's harder. So, all I can say is you guys have a really awesome, I guess, gift, which is the gift of all of these guys at the San Diego Spine Foundation who are there for you. I have called, I think, every single one of them, especially in the first year. And you have to pepper it around. Like you got to text Eastlack, you got to text Ollie, Hanny, and everybody, so that they don't think you're texting each one of them all the time. But really you're asking like a lot of people for help. And that's just like, that's just the key, is just kind of reaching out when you need it. So I think that's really, really important. Don't be shy about that. They will pick up the phone and they will take the time to help you get through some really tough situations. Year 2, I think year 2 is like pretty good because you're kind of getting out of your comfort zone a little bit. You're building up your practice, you're building up your operating room efficiency, and you're kind of just getting your sea legs, you know, and then you're rolling into the boards, which is kind of like the second part of what I'm going to talk about here at the end, and let you guys have some time for questions, hopefully. But basically, this is a period of time where you're just starting to kind of get into a groove, you know, and your board collections probably kind of coming to an end in the early part of your second year, and then taking your boards at the end of your second year. So it's a really great time, but the boards is kind of the biggest thing that kind of hangs over you in this time frame. And we'll get into that in a few minutes. But year 3, this is me, guys. Year 3, okay, is awesome because you are done with your boards. That's all behind you. But I think that you have to be really careful because as you look out onto your patients and people that come into your office, you're like, okay, well, I passed my boards. I'm board certified orthopedic spine surgeon. Blah blah blah. Let me take on this case that I probably would have passed on before, or sent on to the tertiary care center or whatever, and you can get into trouble. And so what I mean is that as your skill set expands and as your confidence expands, you're going to be taking on more complex cases potentially, and then you're going to be sort of like um, you know, losing some sleep again, you know, whereas, you know, you were kind of like, hey, when you were hitting singles and doubles, you know, sort of chip shots, whatever, and they were doing well. And now you're taking on bigger, more complex cases, and you're getting more, you know, more problems. That can be really challenging. So you got to kind of come to grips with that. And I don't really know where I stand with that yet, but this is, sometimes this is me in this picture. Okay, so I'm going to pause there and talk about the boards a little bit. I think that there were some questions that came up about this, and people always ask me about the boards, and so it's a huge part of your first couple of years in practice. So basically, be all my best advice. You know, I can't sum this up all in 5 minutes, but my best advice is be careful and thoughtful about your decision making on every single case. Okay, that's number one. So just not just looking at the image for 5 minutes or 5 seconds and being like, okay, you need this, and going in and booking the case. I mean, take your time and really drill down into every single patient and find out and make sure you're 1,000% sure of what your diagnosis is and what your plan is, your surgical plan is, before you take that patient to the OR. There's nothing that should be done willy-nilly in this really ever, but certainly not during your board collection period. Definitely, again, lean on your mentors and colleagues for advice. And then this other point, be careful about the cases that you select to do right out of the gate in sort of the first 6 months of your practice. Complications that you have from that period of time are going to end up on your boards. So if you're like, okay, well, I can come out of fellowship and I can do any cases I want until 6 months because that's not going to be on my board collection, don't think about it that way. You still have to think about, you know, being thoughtful about which cases you're taking on, not biting off more than you can chew, et cetera, because uh, those cases can come back to haunt you during your board collection, because you're going to have to take those complications back to the OR. Next piece of advice is be organized. Okay, I'm going to show you guys a little bit about what I did to stay organized, just very briefly. So each case that gets picked should be kind of, I put it all into a digital file cabinet, okay? And then within each of these file cabinets, folders in Google Drive, I would have every single X-ray labeled, every single MRI slice that was submitted labeled, and sort of detailed and put in order that you want to have it presented. And then this is the biggest thing. So when you have a case, each case is going to come with a summary. Fill out that summary as much as you possibly can. You're going to hit like character limits and things like that. And if you have questions about it, again, as it gets closer for you, let me know, because I'll be able to walk you through what I did and where I think this is helpful. Some people that I took the boards with had told me that they didn't fill out any of this information. They just did it really perfunctory. And then they had to go back, a week or two before the boards and look through all of their patient files and sift through office notes and whatever. My biggest piece of advice is type up all of this when you submit it for to the board, and then you will have it in PDF format, and it will be available for you to review. And then you just have a full, a full stack of all these patients with everything you need right in front of you digitally, so you can get after it. And you can obviously print all this stuff too if you want to do it that way. But I think that's my best advice for the boards and organizationally. So I'll open it up to questions. I tried to kind of give you guys a very kind of nice brief overview, but hopefully you guys have some questions and we can chat about it.
Sorry, you go.
You can go first.
So
Questions.
I don't know exactly like the practice environment you stepped in. First of all, thank you. That was a great talk. That was super helpful, especially with the board stuff.
Yeah.
I have questions on that too, but I'm not sure exactly what it was like where you stepped into, but how long did it take you to get busy? Like, did you have to start from scratch building a like referral base, or was that already built up?
Yeah, so I felt like I was kind of lucky because we had two busy spine surgeons in my practice, and they had a third partner who left a couple years ahead of time, a couple years before I got there. So there was kind of like some built up demand for my position, kind of geographically and clinically. So I think that I got a little bit lucky in that regard, where I was able to get reasonably busy pretty quickly. But I think it really depends on what type of practice you walk into. I mean, I had people, in my neighborhood, like guys that joined Rothman and stuff, that they're competing with like 20 other spine surgeons in the Philadelphia area on the other side of the river, and couldn't really get to their 35 cases that they needed to get for their board. So it really just depends on what group you join, your geography and stuff like that. It all makes a difference as to how busy you're going to be. But I would say that the norm is it's more the norm to be pretty slow, which
Yeah.
allows you to kind of have some time to build up, to build your practice, and to get out there and kind of meet people, and like just help to make your OR and your office run more efficiently and things like that as best you can. Like I still don't feel like I've hit the ball out of the park with my clinic efficiency. I run behind all the time. I don't know how to stop that. It's really, really a huge challenge. And when it's you, it really hurts, because the whole waiting room is like, it's like, oh, Ames is an hour behind again. And then there's other doctors in the office, and there's, it's just like, it's not a good look to just constantly be behind. But at the same time, giving each patient the quality time that they need is really, really important. So my philosophy is like, look, sit there and listen to the patients. Don't cut them off. Don't be abrupt. And if that causes you to be behind a little bit, make up that time where you can. The one patient that's like super happy post-op, that like doesn't need to be sort of coddled, like high five them and let them go, and then keep moving on fast, and spend the time where you need it to be spent. So it's tough, man. There's no easy solutions to these questions and problems.
Yeah, and
Rob.
then oh, sorry.
Hey, Rob, it's Bagger, man. How you doing, man?
Hey, what's up?
Awesome talk. I would say
Thanks.
one of the really frustrating things that I think you might experience coming out of our fellowship is just you're used to going 1,000 miles an hour, doing 5 cases a day, doing cases at night. The whole year is a lot, and then you start your practice and things come to a screeching halt. And
Yeah.
that's something that I think I struggled with that a lot, because I was like, why am I not busy? What's going on here? And I felt this sense of anxiety because I wasn't doing 5 cases a day.
Right.
But I would say, take your time, build slowly. It's for the long haul. You're not doing it for any short term gains. So the cases will come. It can take up to a couple of years, 2 to 3 years to build up your practice, but be patient because sometimes you get stuck with not knowing what to do with yourself when you have so much free time. But I would encourage you to like work on your templates, try to become more efficient in your office, talk to the OR staff, become more efficient with them in terms of what you need. And then before you know it, things will pick up.
And
Yeah,
did you, when it
totally.
comes to like templates and stuff, did you guys just keep essentially a lot of the fellowship ones,
Yeah,
or
so
did you create
I
your own, or
took
how was that?
no, I took a lot from the guys at Scripps. There's no doubt. I think that the best advice is to take what you can from Scripts, right? Like the templates and also the OR preference cards. But there's also like stuff on the OR preference cards that you're going to get to the hospital and they're going to say like, oh, we don't have that, or
Yeah.
we have something different. And I would just be open to that, because the best thing that happened to me, I mean, can't think of any real examples, but I remember it happened a lot where they were like, oh, we don't have that, but we have this. And like, oh, the neurosurgeons are using this. And I'm like, oh, let me take a look at that, like, oh, one good example is like a curved MIS burr tip. Well, I don't remember us having that, but that's been really useful to me for doing tube cases and stuff like that. So, that I never used that before, but like the first week I was there, they were like, oh, try this. And I was like, oh, this is actually really nice. So don't be like super rigid with the things that you used in fellowship. I mean, to a certain degree, you have to be like for laterals and stuff like that. Don't go and like change your, for that type of thing. Don't go and like sort of try to change up the whole workflow. But for certain things, it's good to be flexible, but definitely working off of those OR preference cards and stuff is a good idea.
Um, how would you say your approach was for things like, doing your first laminoplasty or thoracic disc herniation, or just these like one-off, like uncommon things that
Right.
if we saw probably everything like, like 3 to 4 to 5 times this year, but for those where it's not the routine, like how is your approach to doing those for the first time?
Yeah. I mean, just just get it done, man. I mean, I think there's really like, it's tough. Like, how are you gonna, I mean, if you did something 5 times in fellowship, that's like 5 reps. But the thing is about your skill set is like, you guys are so well trained. You don't realize like how well trained you are compared to the vast majority of people coming out. I really believe this. Talking to all my colleagues that are in my year that took boards with me and things like that, and listening to their approach to surgery and their complications and all of the things that you can imagine, from like, looking at social media, looking at LinkedIn, looking at what people are doing out there. I mean, guys, you guys are incredible as you are right now. You know what I mean? So be confident in that. Like a laminoplasty, okay, fine. You didn't do 100 laminoplasties, but how many posterior cervical cases did you do? So you're using a lot, you're using all of these similar, all these skill sets. There's crossover, from what you've done on other cases to these more complex and more rare cases. So just be confident in your skill set, and recognize that you're going to have to jump into the deep end at some point, and just got to do it.
Yeah, big shout out to the team here. I think David and I both kind of left our BAMP meeting with a similar mindset to what you just described. Like just talking to other fellows and whatnot. We feel very comfortable with their training, I think. How do you go about, like, so speaking along those lines, like forming relationships with like vascular or plastics,
Right.
or people like that, like, not necessarily spine, but the adjacent specialty. I mean, even like rheumatology, neurology, like how do you go about finding good people for referrals or help?
I was pretty lucky because I came into a practice that had some of those things set up already. It was like, oh, who do you use for ALIF exposures? And it was like this guy. And then who do you use for plastics when you need their help? It's this guy. So I was kind of lucky. I don't have any like pearls for that, because to be honest with you, I felt like pretty fortunate to kind of walk into a situation where it's like, oh, we're using these guys for this, that, and the other. But I will tell you that like just meeting with different people around the hospital and just chatting with people and being kind of proactive about introducing yourself around in the OR lounge, etc. The guy that I use now for my exposures for ALIFs, none of my partners use, because I met him at a separate facility where I work and they don't. So that was something where it was just like an organic thing where we met, and he was open to, he had done some exposures in the past and he was open to doing it more. And it turns out like he's the man, like he's my guy. So it's great. I mean, I don't I think just being open and being proactive about introducing yourself around the hospital and talking to different surgeons is what you need to do. I would say one more thing about social media. I don't know. I mean, I was thinking about including it like in the slides and stuff, and it depends on it depends on the practice you're in. It depends on your geography and your sort of like how much competition you have around you as to whether or not you really quote unquote need that to be a part of your practice or to build your practice. There's other talks online about how to, that's like, other places that will tell you about how to incorporate social media into your practice. But I've kind of found that it has been less helpful to me certainly has not been helpful, I don't think, in getting patients sent to me. I don't think it's been helpful at all. And in my opinion, I've come through an evolution of this where like I was involved in it a lot in the beginning and I thought that it was helpful. And now I'm finding that it's really more just people chirping about like pumping themselves up online and showing everybody what you did yesterday, which was so super cool. And I don't know if it's really a lot of value, to be honest. I have changed my position on that a little bit, but it might be helpful for you if you're in a really saturated market, to get patients from Instagram or whatever. But
do you, along those lines, do you consider like learning endoscopy or anything like that?
Yeah. So I'm laughing because it's funny that you mentioned that, because it's something that's been on my radar for the last 18 months. And I said in 2024, I'm going to learn how to do some basic endo cases. That was like a goal of mine. And I visited some surgeons and I watched people how they did their technique and sort of looked at like biportal endoscopy and all this different stuff. And I just am not totally sold yet that it's any really that much better. I don't know. I mean, I certainly think that there are some things that could be pretty useful if you get really slick at it. There's some things that could be very beneficial and useful for you to have in your toolbox. But like to just do a basic, like let's say a laminotomy or microdiscectomy, I don't know. I'm not sure that there's a lot of value there. You should better talk to the endo guys about it than me. But I'm definitely thinking about incorporating it in my practice at some point, but I'm not quite there yet. I don't know if I'm convinced.
In terms of your help, what was your setup like starting? Like, I know Steven Steffen, like day one, I saw him walking around the hospital with his nurse rounding, and I'm like,
wait, he has a nurse that rounds with him? That's amazing. I don't have
day one. I was like, how do I get that? But
I just have to.
What?
I just have to find patients
They're a
to
little
round on
pampered
first.
here,
But
David and Michael.
He has to find patients. Yeah, that's the first thing. That's the first thing.
Because my practice, they're like, oh, we'll see how well you do, and then like based on that, I know I've heard other people say like there's like 10,000 to 12,000 RVU mark before you should consider hiring a PA.
Right.
But at the end of the day, it's like direct overhead is like it's basically out of your collections to cover a PA.
Yeah.
And Mike was telling me you can structure it so they can run their own clinic and they can cover their own costs to some extent. But like, how has your experience been with navigating
Well,
that?
only if you have patience for them to see.
Right.
Right.
It's-
So that's the key, right? And again, I probably am not, I don't have as much experience in that regard because when I started, the way our group was set up was there was like shared OR PAs, okay, but nobody had a PA in clinic with them. So that's, it's not my ideal. Like I would like to have a PA side by side with me, them having their schedule, me having mine, and us kind of bouncing back and forth, right? That's how like Bruffy's clinic is set up. I think that's perfect, my opinion. Have like 35 or whatever people on, or 40, I don't know, however many, and then kind of sharing and bouncing back and forth. And then having the OR experience as well, and doing it that way, certainly the PA overhead would be covered. In my group, it was basically like, okay, you just have a PA for the OR, and then everything else is on you, like rounding and the office. So it wasn't as kind of as much help, quote unquote, for me in the beginning as I would have hoped, but it's worked out fine, and I've been fine with the setup. So it depends on your practice and what they're going to be able to offer you. I would say fight for a PA in the OR with you, like one that you can share with another surgeon or something, and have them be with you all the time, because they're going to help you make your efficiency in the OR really, really much better than it would be otherwise if you're with the same person assisting you. There's no comparison, or there's no substitute for that value.
Have you heard of anyone using just like a first assist and having the same like first assist person, or do you feel like the medical training of a PA like helps, or
I think that a first assist in the OR with you, if they know your steps and they know everything about you, and they know your preferences, and they can be the ones to be like a second set of eyes and ears in the OR for you, that would be certainly just as helpful. But they have to have a level of like, I don't want to say expertise, but like they have to be able to like recognize, okay, they need to be proactive in like OR setup and making sure that things are running smoothly for you, not just kind of like handing you an instrument. You know what I mean? So that would be a matter of like, if you're going to hire a RFNA or something like that, then that would be in the discussion of like, okay, this is what your expectations are for in the OR. That would be pretty helpful, I think. Again, you're asking someone who's like 3 years into practice for advice. Maybe ask Ollie. I mean, I don't know. Like, look at, he's right there. Like he's like an old timer now. I mean, geez, how many years out are you? He and I are the same age, but he's like in year 10 of practice.
10 years, man.
Old man.
That's great.
I don't know, is it?
It seems great.
Yeah, I know.
Yeah. Good.
It's good to see you, Rob.
I know. It's
He's
good to see all your faces.
He's also just about the same starting point as you, though, Rob. In a new practice, so some of the same things.
He's back to grinding.
Well, I bet. Yeah, I mean, even if you're an old guy joining a new practice, you have to go through some of the same doldrums.
Yeah.
Hey, come on! It's like I'm not that old, man.
I mean, listen, man. 10 years.
You're pretty old.
Relative.
You're pretty old.
Hey, I want to add one thing for the young guys that Rob touched on a little bit. But when you start, you're going to have complications and problems. Spend a lot of extra time with those patients, even if it means visiting them at the skilled nursing facility. But that's where you can run behind in clinic, or you tell your clinic staff, hey, schedule them a longer visit, because spending a lot more time with them goes a long way to avoid some of the other issues that come up with complications versus being abrupt or short shrift with them.
Yeah, I would definitely second that. I mean, and there's problems, like if you have patients that have complications and then they end up going to skilled nursing because they can't mobilize or whatever, they might not show up in your office for follow-ups because they're at a SNF and the SNF transportation isn't set up. I mean, I've had patients where I've been like waiting for them to follow up. And they're like, oh, well, they're at a sniff, but that's the worst sniff on planet Earth. And they won't transport patients unless it's out of pocket for the patient. So I have gone to skilled nursing facilities to track down my patients, because it's like, if you don't do that, you're never going to see them. You know, they're not going to follow up with you. You know, they could be gone. They could be lost. So it's important to keep track of them. I totally agree with that. And to call them and to call the families. If you have a patient that dies, I mean, call the family, you know, I mean, be there for them, you know. This is a tough job, but you got to be a human being first, you know, be a human being first, and then be a spine surgeon second, and you'll do fine.
Hey Rob, was there opportunity for you to supplement your practice with call? Did you take a lot of call, like trauma call or regular spine call, or even just general ortho call?
So general ortho, I was basically discouraged from doing that because the general ortho guys were like, they didn't really want another guy in that call pool. The group that I joined, we just had a pretty easy split, 3-way split with the call, and there's 3 of us. So Q3 weekends, Q3 weekday call, whatever. It really wasn't that disruptive to me, and there wasn't a whole lot of opportunity to take extra call. But I know, depending on your, like, if you're at a busier trauma center, there may be opportunities to get more call, but there also may not be. There may be like neurosurgery groups or whatever that are pretty protective of that call.
Yeah.
You know, and that's the flip side of that coin, is like, you could want all the call in the world. It doesn't mean you're going to get it, you know. So that there's some other hospital systems that are kind of tougher like that. Dr. Mundus, you still there? He left. He left. He couldn't handle it after the mom picture.
That was awesome, Rob.
Yeah,
Thanks for
Rob,
doing
good
that for
to
me,
see
guys.
Dr. A, good to hear your voice.
I can't believe
Sorry,
Oh, there you are.
yeah,
Oh, there he is.
I missed
The
Not
man.
in urgent care this time. Oh man.
that, but I will review the record. So
Oh, okay.
hope I can see the family and
Yeah,
see you in person.
absolutely. All right.
Take care.
Well, it's
Gentlemen.
late your time, huh?
All right, Rob. Thanks, man.
Yeah, well, it's 9, it's 9:45. Gotta get my clinic started. It's all good though. I had a late morning, so
Rob, are you coming to the reunion next month?
I'm not coming this year because I'm doing something kind of fun. I'm going to be my kids are at sleepaway camp, and I'm gonna be the camp doctor for 2 weeks.
Oh, nice.
In the Adirondacks. So I'm gonna be treating a lot of ear infections and a lot of stuff that I probably shouldn't be treating, but it'll be fun. It'll be fun. Like, yeah, you want the orthopedist dosing the antibiotic to your child for his ear infection. Yeah, that's gonna work out. All right, guys.
All right, man. Have a good
Hey,
day.
Rob.
Hey, good luck, everybody.
Appreciate it.
Take
Thank
care.
you.
Bye.